Welcome to next session. So ISMSICS session. For this session, chair is Dr. Prakash Marate, but yes, Dr. Prakash Marate is busy in another session. He will be joining shortly. So I am the co-chairman for this session, Dr. BNR Subudhi, myself, and with me, Dr. Parikit Gogate. Please, sir, come. And convener for this program is Dr. Satanshu Mathur. I don't think I'm seeing Satanshu Mathur. Co-convener Dr. Srinivas Joshi and Dr. Deepak Mishra. I think both of them are busy in some other hall. We have the moderator, Dr. Sabyasachi Patnaik. Please do come forward, Dr. Sabyasachi Patnaik. And Dr. Birajdar. Yeah, Birajdar instead of Dr. Mandar Paranspe. In place of Dr. Mandar Paranspe, Dr. Birajdar will be the moderator for this session. So we'll get the first talk. I think Dr. Parikit will get the first talk because Dr. Prakash is busy with another session. He will join shortly. And next is my talk. Then after that, Dr. Ashok Nanda, Dr. Satyajit Sinha, Dr. Jatindra Bali, Dr. Shiv Prasad Sahu. So these are the speakers. I think Dr. Sabyasachi Patnaik will moderate the session. Please do come. And I request Dr. Parikit to start the talk. So I think everybody knows Dr. Parikit is the Vice Chairman for our International Society for the Small Incision Cataract Surgery. So he is with me. He will give the first talk. Please.
Thank you, Dr. Subudhi, sir. Well, I am speaking in a hall full of great cataract surgeons. So this is just a small talk on the astigmatism management in manual small incision cataract surgery. Well, all of us Indian ophthalmologists are very, very good in doing cataract surgery, and I would say perhaps the best in the world, second to none. Not just India, all South Asian ophthalmologists. And over the last few decades, phacoemulsification has become a surgery of choice for almost all of us in private practice settings and in many institutes. And many people consider it exclusively as perhaps the best kind of cataract surgery that can be done. But then managing astigmatism can also be done in small incision cataract surgery, and we can get equally good results with that. If you can set the timer, it is giving a different one. Well, we all know astigmatism can be a limiting factor in patient satisfaction. We surgeons are happy with best corrected visual acuity, but today patients consider the success of surgery on unaided visual acuity. So the correct IOL power takes care of the sphere, but then we have to take care of the cylinder. When I did my residency in 1990s, this was the most common refraction that we gave. Well, when we started IOLs in 95, the sphere went away. When the phaco SICS started, the cylinder went away. And now with multifocal implants, even the near addition is going away. And when patient goes, they don't want to wear any kind of spectacles. So we all know that when we compare the astigmatism between SICS and phaco, and we have numerous randomized controlled trials to that, the average astigmatism in SICS is about 0.7 to 1. And the astigmatism in phaco is about half a diopter, because obviously the incision is lesser in phaco. So this is what we had published in JCRS, the second large RCT that we had done. There is of course a difference both at 1 week and at 6 weeks. In fact, we also did a meta-analysis comparing 7 head-to-head comparisons between SICS and phaco. And the only differentiating factor is the astigmatism. The dot line that you see is what is the final result, the one in the center. And this, if you will see this quadrilateral, this is completely on one side. So that means that in all the studies, the astigmatism is lesser in phaco for sure. But then it's not just distant vision. If we look at near vision, then in manual small incision cataract surgery, patients get better unaided near vision. Now, we all have seen our phaco patients. We are very happy because the next day they are able to read 6/9. But patient says, doctor, earlier I could see the mobile, earlier I could read my newspaper, now I can't read the newspaper. So we tell them, you can see far so well, but it's not just far, they also need near things, where the astigmatism of SICS helps. So, well, we can use the astigmatism in phaco by doing temporal incisions, incisions on steeper meridians, using LRIs and now toric IOLs. But all of that can be done in SICS too, because scleral tunnel incisions that way are very kind in nature. They are secure, they heal well, they are forgiving. So how can we minimize astigmatism in SICS? One is, of course, we take the astigmatic consideration, the frown incision, which gives best wound stability, gives the least amount of astigmatism. We have the concept of the astigmatically neutral funnel. So if we are doing large black brown cataracts, which a lot of us do, we just have to go more posteriorly. Well, we can use the chevron, we can use the frown, but we also have to understand that in manual SICS, there is a trade-off between lesser astigmatism and corneal clarity. People do 2 mm, 3 mm, 4 mm SICS also, and in expert hands, it works well. But the more we play around in the anterior chamber, more are the chances of endothelial cell loss, and this is something that we can get. And referring cataract patients to corneal colleagues is not the best thing for our practice. So for site of incision, temporal or superior temporal is better. So time to hai aur? In fact, there are now more recent advances. There is Smart SICS by Dr. Rajiv Raut, or there is the Ranjan's marker, or Dr. Sudhir Singh has his own technique, or Dr. Sahu has 3 mm, 2 mm SICS. And they hope, to give not just 6/9 unaided for distance, but N6 or unaided for near. And what is the reason for that? The reason is, like it is in this ad, in which kuch daat achhe hote hain. In it, astigmatism actually gives better unaided near vision. So we all think of astigmatism as a curse, but we can use the astigmatism well to get unaided distance and near vision. It may not be 6/6 N6, but a lot of patients are happy with 6/9, 6/12 and N8 or N10, because even with multifocals, that is what we promise them, 6/9 N8. So if this is the straight incision, if you keep on going behind, these are Dr. Boramani's slides, the astigmatism, as you can see, keeps on reducing. So in superior straight incision, if this is the astigmatism, in a curved incision, it is lesser. We've done a large study on temporal SICS, 2000 patients in Nashik, and manual SICS temporally is also found to be as safe, and the entire Arvind eye care system does temporal SICS. Similarly, we can have temporal straight incisions, we can have temporal curved incisions, and all of them reduce SIA. Always you take incision on the steeper meridian, so since we have the nose in between, we get 180 degrees for the left eye, 180 degrees for the right eye to be able to do that. And if you look at corneal topography, I'll just rush through these slides. Suppose you have a high astigmatism like that, 3.5 diopters. Normally, we would have put a toric lens. But if we take a larger incision, then because the surgically induced astigmatism is more, we don't need a toric lens, and we can have a patient who's 6/9 N8. So we can even put a multifocal. So instead of doing a multifocal toric with a phaco, we can do a multifocal toric with SICS. So, and of course, it's going to save the patient money. We will earn more money when we do that. So like a superior nasal incision, if it is done, we get almost 6/9 vision. Even the near vision is very, very good. So instead of calling it surgically induced astigmatism, let's call it surgically corrected astigmatism. And it's many a times a customized incision cataract surgery. So we do a lot of patients, a lot of our poor patients are patients who cannot pay that well. We are doing SICS. If we really just plan a bit, give it time, we will be able to give better unaided distance and near vision to these patients. And patients will be happy, and well, happy patients are what shall we say, our best advertisers. And there is so much that can be done with manual SICS. And there are kinds of cataract, brown, black cataract, subluxated lenses, decompensated corneas, where SICS is definitely better than phaco. So thank you once more for giving me this opportunity and hearing me out. Thank you.
Thank you, Dr. Parikit, for the nice presentation. Yeah, one question, Dr. Vishal. Yeah. Please give the mic, please.
I have found against the rule to be better for near vision, but not that good for with the rule. So what is your experience for that?
So as I said, we need more data and we need more publications on this. So in the November issue of IGO, there were articles only on SICS, which I think is still inadequate. Because if you look at phacoemulsification, there will be literally thousands of articles on the PubMed. But there are not even few hundred articles for SICS. So we need more data on it. So if you do that, please write it up and publish it.
Yeah. Moderate grade of against the rule gives good near vision up to N8, as you said. That's what I found.
And near vision is now perhaps more important. People look at their phones or at near things more times than they look at far things. So yeah.
So that's a satisfied patient. You want a satisfied patient.
Yeah.
So you got the numbers and
Yes,
you
sir.
got a satisfied patient. One more question.
Yes, sir.
Are you exactly predictable that you can use so much by such a small incision or a 5 mm incision or a 4 mm incision, how much amount of astigmatism goes down if you want to
Sir,
treat it properly?
There are, like Dr. Boramani has a series, he's done a lot of that. Now, if you follow your patients you track them regularly, it is possible to get it. The variability will be slightly more because the incision is larger. But when we do phaco, or even when we put a multifocal implant, when we want bang on zero target, what do? We measure the A scan again, we measure the keratometry again. We think twice before putting or taking an incision. So if the same kind of a mindset, and you can say the preparation is done for manual small incision cataract surgery, it will give us equally good results. A lot of us do manual SICS as a fallback technique, or when you have to convert, or you think something has gone wrong, or you have to do say 15 surgeries today, so it's a faster or a cheaper way to do it.
According to your experience, what you feel that this much amount of astigmatism we can correct with the help
So
of
in my
SICS?
hands,
Yes.
I don't do very small incision SICS. I do a 6 millimeter tunnel because I have seen if I try to make smaller tunnels, the cornea gets affected, and even that tissue is very important. I mean, yes, astigmatism is important, but so is endothelial cell count and corneal clarity. So in my hands, I would have say 1 diopter. If it's a very black brown cataract, 1.2 diopters of astigmatism.
It is always predictable the same in each case?
Almost. Yeah.
Okay. Thank you very much, Dr. Parikit, for your nice talk, followed by a lot of discussions. So I think we should move to the next talk. Next talk is mine. I am Dr. BNR Subuddhi. It's not moving. It's not moving. It's not moving.
Hello, good morning all. I think I'm very sorry to come late because I was having talk in other hall.
Okay.
This ISMSICS session has been designed in a nice way so that it gets benefited for all the members. There was a hitch in between. Dr. Subudhi could not start. Now I think it is on.
Okay.
Dr.
Right.
Subudhi can start.
Okay. Thank you, Dr. Prakash. My talk is on the PCR. As you know, the PCR is one of the most dreaded complication everybody faces in life. I don't think who has done surgery without causing a PCR. So, first of all, I must thank the IOS midterm conference, auspice bearers, the LOC for organizing such a beautiful conference and giving us an opportunity to hold a ISMSICS session. As I told you, the poster capsule is one of the most undesirable intraoperative complications everybody faces in his life, and it is more common in with the newcomers, whether it's a ECCE, whether it's a SICS or FECO, whatever the surgery, everybody faces a PCR. And once the PCR is occurred, how to manage that, that's very important. But before, I think, selecting a case for the cataract surgery, you must take into consideration all these factors, whether the patient hypertensive, diabetic, the high myopia, then any blunt trauma received in the past, because you expect something. Mostly old age people, it's very common because they are associated with so many complicated factors with that, post-polar and Morgan cataracts and pseudo-explorer syndrome, which is very common in our CAM patients. So in these patients, we expect some complications, and one of the most undesirable complications the PCR. So these are the 4 things almost associated in many of the cases, because our cases are very old patients, senile patients, mostly they belong to the rural area, and all these things are associated with one case. And post-polar cataract is also seen in younger population. So these are the 2 most important factors we come across in our preoperative evaluation of the patient. So other operative factors in a poorly dilated pupil, poor visualization due to some corneal opacity, then inadequate hypotony is maintained, not maintained before surgery. And while doing a capsulotomy, if there is any radial extension, then forceful hydrodissection, inadequate capsulotomy, blind cortical clone, all these operative factors are responsible for the development of a post-capsular rupture leading to vitreous loss. So these are the 3 most important factors we see in our day-to-day factors. I don't want to. So how to recognize that with the PCTR? As you go on doing the surgery, suddenly there will be deepening of the antechamber, and nucleus does not rotate, whether it's a FECO or SICS, whatever you want to do, but at that time you'll see that the nucleus is not rotating. And vitreous may be present in the antechamber, maybe through one corner. We have to take care. And if it is a central posterior capsular tear, it appears as an oval, a round area, where the peripheral tear appears as an oval area with a complex convex edge toward the center. So once it is occurred, don't get panic. That's the most important, because if it's a VIP, and definitely you become panic, and panic creates more complications than the vitreous, PCR itself. So we must frequently, see that the management depends upon the position of the tear, extent of the tear, and whether associated vitreous are lost or not, and the stage of SICS during which it has occurred. So if the PCR happens, again I say that don't panic. Try to maintain antechamber with visco. As you remove the cannula, put visco from the side port, and see that your vitrectomy set is already ready with you, and keep your venous scissor also ready in case the machine doesn't start. So assess the extent of the PCR, either it's small or big, and whether the vitreous disturbance, if there is vitreous loss or not. Depending on these 2 factors, your management depends. If there is no vitreous loss, only there is a PCR. If it is a small PCR, still you can proceed. So stop irrigation and take out what is the cortical matter left behind, and assess the case again. If the tear is central, inject viscoelastics. Even also sometimes you can give under air also. PCL is placed, and the tear is peripheral. See that again with the under visco, and try to rotate the PCR, IOL in such a way that it does not extend the tear. These are some of the methods. So if there is no vitreous loss, but still there is a big PCR, and the PCAPS is not sufficient enough to support an IOL. So remove as much of the cortical matter as possible. Don't leave cortical matter. They may induce more reaction with vitreous in the antechamber. And again, after injecting the visco, you see whether you can, with the IOL can be placed in the remnant of cortical cortex, whatever left behind. And if you are very sure that you can place the IOL without any disturbance, so you can place it. Otherwise, you can consider 2 other things, or the AC IOL or scleral fixation IOL. If I say that if you placed AC IOL in the better way, I think still you can manage the cataract, because many times I have seen the long, even after a gap of 30-40 years, you have seen that AC IOL is well placed in the antechamber, because we have placed in the properly. If not, you have got alternative sclera fixed IOLs, even iris fixed IOLs also. But if there is a vitreous loss, it is very difficult again. If the small PCR vitreous loss, try to remove as much vitreous possible from the antechamber, clean the pupillary area, and still if you feel that IOL can be placed, you can place the IOL and continue with the surgery. But if it's a large PCR, vitrectomy should be performed first. Clean the again antechamber full of vitreous. If you are still doubt, I think you would inject hydrocortisone, see that vitreous is cleared from the antechamber and pupillary area also. If the intercapsule is sufficient enough, place a PCIOL. If they're not sufficient, you can again consider these two other methods, suppose ACIOL, fixation IOL. Referring to vitreous surgeon, yes, drop nucleus, never do fishing. That's very important thing. Many times in youngsters, they feel that, yes, I can remove the nucleus which is dropping. They put a bacteria into the posterior chamber and bacteria into the vitreous and try to remove it, and they cause more disaster. Even if they succeed to remove the nucleus, but ultimately they may lead to the retinal detachment at a later stage. So preferably keep epikick, which helps to prepare the PPB, and after implantation send them for the peripheral retinal evaluation also. So it's, these are the algorithm we follow in case of any sorry, I want to show a bit manual bit. So remove whatever the nucleus pieces left behind. Then try to remove. Don't hydrate the vitreous. If you hydrate, more amount of vitreous will come forward, and it's just only with a swab and a manual Banner scissor, we remove all the vitreous. Because many times the vitreous instrument is not available, vitrectomy is not available, sometimes it is not working. In those cases, probably you can go with the Banner scissor. Remove all the vitreous from the pupillary area and enter chamber, see that no vitreous is left behind to cause a reaction later or secondary glaucoma. Then place the IOL carefully without disturbing. And we have seen in many cases the IOL remain in place quite satisfactorily. So one more slide, please. So I will finish it. Okay. So prevention is better than cure. So pre-operative evaluation is very important to possible risk factors, and adequate echinacea and message to be done to mention the soft IOL. If at all necessary, you can give a manual. Mannitol should be given intravenously. Before surgery, adequate visualization is very important. Your microscope must be ready according to your IPD, and care should be exercised during the enterocapsulotomy, not to extend the capsulotomy wound. So keep cool. Everybody's hand vitreous is lost. So don't worry. If you're a youngster, if you're a beginner, don't worry that the vitreous has come, you're disturbed. No. And assess the PCR and properly manage. Thank you very much for the patient hearing. And I thank again ISMSICS, and I think many of your people sitting here are members of ISMSICS, but I request all of you to become ISMSICS member. So
thank you, Dr. Subuddhi sir, for such a wonderful explaining it so lucidly. PCR is something which all of us are afraid of and we have nightmares about. So you told in such a very easy way. Now I would like to invite our senior from Maharashtra, Dr. Prakash Marathe, to give this talk. And then followed by Dr. Ashok Nanda sir.
Hello. It is not projected. You have started the timer. It is not moving. Hello, good morning. I think ISMSICS session is advised by Dr. Amulya Sahu, who is the founder chairman, Dr. Jagannath Moramani, who is the chairman, or vice chairman, Dr. Parikshit Gopte, and all the team has taken tremendous efforts to design this program. And ISMSICS is working for SICS promotion in India as well as abroad. The topic allotted to me is SICS scenario in India and abroad. In India, people talk about PHECO, they knew about ECC, but they also know about SICS. So SICS promotion comparatively was easy in India. But in foreign countries like America, Australia, what we have observed, they are being taught ECC in their residency days and directly FECO. So if some complication occurs in FECO, they do not know how to convert. So SICS is not known to them. And that is the worst thing because it is not ticked in their curriculum. So it is the job of ISMSICS body to promote SICS abroad. And we have started various chapters in various countries across the world. This particular scenario in abroad, you should remember, there was COVID. In COVID, immature cataracts got matured, hyper-matured, black, brown, and whatnot. Now the surgeons, they know about FECO, and in FECO, they know how to tackle the soft cataract. But they didn't have any training to tackle black and brown cataract. Now the problem was what to do. One of the Indian surgeons who was there in Australia started doing SICS. And there was so much of crowd gathered in her OT, and there was a big scene. What is this different technique? How the whole nucleus can come out, and how the vision is regained after the surgery. So this was new to them. This is a fact, what I am telling you. So mature cataracts handling is difficult in foreign countries because they do not have any experience to tackle the mature cataract. Recently I have seen one patient from America who had PLPR. The person was well educated, but because of that insurance technique and waiting period in America, he was not getting controlled diabetes, and so surgery was not done. He came to India and the surgery was done. Such sort of hypermature patients even are not seen in India, but it was seen in America because of that particular circle of their reference. So extracapillary to FECO, that is the thing in abroad, whereas SICS must be the in-between step, which is there in India. So complicated cases and hypermature cases tackling is very difficult. In India, always compared with FECO, that is one of the options. It is the art of hand, that is manual surgery. Like handwriting, we are forgetting handwriting because we are typing on mobile and computer. Then spelling, we don't need to remember, it is auto-spelled. Drawing, you are forgetting, it is done on computers. So non-machine dependent, that is the thing which you are going to carry with SICS. So one of my friends, Dr. Rajiv Raut, is charging 2 lakhs. That's what he has said, you can quote me. He is saying the cost of the lens is 5,000. But my charges, surgical charges are 1,95,000. And he operates SICS. He says, I don't know FECO. This is my technique, if you want to come, and there is a waiting list. So this is the way you should learn. You should charge your own skills, your technique. It is the art and not the machine. You shouldn't correlate your charges with your FECO machine and your IOL. So it goes to masses, easily available in India. And no inferiority complex is the mission of ISMSICS. So better understanding of wound reconstruction to eliminate astigmatism has been done by even SICS surgeons. Myopic astigmatism is little there in SICS, but it is better for near vision, remember. Minimally invasive, even 2 mm is done by Dr. Amulya Sahu nowadays. Astigmatism is well corrected by Dr. Boramani's technique. Bifocality is done by smart SICS, Dr. Rajiv Raut's technique. So this is also minimally invasive. So better nucleus delivery techniques are available. Technique to give bifocality, that is smart SICS by Dr. Rajiv Raut. So India is exporting this technology to all third world countries. So better acceptance of SICS by thinking ophthalmologists of developed countries. It was resistance for America and Australia to form ISMSICS chapter there because they were afraid. Insurance companies, government rules and regulations, university, it is not written in our syllabus how to do, why to do. But we have promoted. And now they are saying, we will send our ophthalmologists to India, train them in a proper way, give them training. We will ask our patients to get that surgery done. Basically, they should include it that particular surgery in their insurance, their government's rules and regulations. So acceptance will be there. Like poor countries in Africa, they have accepted in a nice way. Only the problem was about developed countries. So thinking ophthalmologists in all type of countries, including developed countries, is being done. So what next to SICS? We shouldn't wait here. What we should do? That is promoting SICS and quality cataract surgery everywhere. It must come in scientific journals. It should get very well promoted there. because documentation is very important. National and international masters must be there, like simulators are there. But teaching, there are faculty going everywhere in the world. Dr. Parishit Gopte has been doing wonderful job in that particular aspect. So wet labs and hands-on training is done. At ISMSICS conferences recently, which was held at Chandigarh, we had that simulator training. And it is being accepted everywhere. We have got various centers where the training is being given. There are medical colleges, and at medical colleges, suppose the phaco surgeon is there and SICS surgeon is not there, he may not promote. So catch them young. Teach your PGs at residents about this SICS surgery. At district hospitals, taluka hospitals, primary health centers, wherever the cataract surgery is done, this SICS technique is perfect and useful in India. You must promote that. You should teach your juniors and even seniors should promote that surgery in a nice way. So contribution of India, that is Indian subcontinent, that is India, Nepal, Bangladesh and Pakistan to the world of ophthalmology. Not just economical and easy, but classy and has ability to deliver effective outcomes unaided 6, 9 and N6. I think I am not exceeding my time. So manual SICS, it will remain, of course, not only remain, it will not vanish at all, but it will flourish. Remember that. And with these words, this is my humble appeal and request all of you to vote and support.
A very prolific surgeon, a great phaco surgeon and also great SICS surgeon from Bhubaneswar. Dr. Nanda's surgeries were recently demonstrated by the AIOS team, and they had asked him to show 3 surgeries in that 2 hours time. But Dr. Nanda usually does about 15 to 20. So when in the first half an hour only all 3 surgeries were done, he asked the AIOS secretary whether I can show more. So she said, no, you have been given 2 hours. So, you know, all the surgeons got a treat to watch him do so many of them. And in response to Dr. Marathi's this about the role of SICS in the developed world, in fact, I had written once an editorial in the Royal Australia and New Zealand Colleges Journal, that is Clinical and Experimental Ophthalmology, about the role of SICS in the developed world. And Professor Ravi Thomas, who's based in Australia, has commented on that. So he says, when somebody knows SICS and does phaco, it is like flying a plane with a parachute. If he knows only phaco and he knows no other technique of cataract surgery, then it's like flying a plane without having a parachute. And it's always risky flying a plane without a parachute because you never know when you will need it. So over to Dr. Nanda, sir.
Thank you, sir. I'll be talking on Descemet's detachment in cataract surgery, which is not very uncommon. The reasons why you should be knowing about Descemet's detachment is important, then only we can prevent and manage it. The incidence of DM detachment is about 0.5 to 2.5%, and it is more common after wound construction by keratones rather than femtolaser. So we divide the risk factors of DM detachment to patient-related factors and surgical-related factors. In the patient-related factors, loose DM is present in people who have a mutation of TGF beta-induced gene dysfunction of keratoepithelial protein, which leads to the weak adhesion of DM to the posterior stroma. The other causes are mature cataract, hard cataracts with pseudoexfoliation, Fuchs endothelial dystrophy, and of course old age. Amongst the surgical factors, uniplanar and anteriorly placed incisions are most important. Blunt keratome causing irregular internal wound, careless instrument handling, inserting instruments with collapsed anterior chamber, inserting phaco tip or hydrocannula with the irrigation on, forming anterior chamber at the end of the surgery. That is another way where it can go wrong, and longer phaco time is where the DM detachment has been found to be more. These are some videos which are just highlighting how the DM detachment can occur. This is a blunt instrument. You can see the surgeon is trying to push, and that is where he can lead to a DM detachment. Through a small side cut, if you are trying to put a long chopper, that's where again the stripping of the DM can occur. Sometimes a small retained nucleus fragment, if you are trying to take it out, that is where hydrating the wounds is the place where it can happen, and putting an instrument through a small port, that's again where it can go wrong. So what are the signs and symptoms? Intraoperatively, you will see a fluid wave which passes between the Descemet's membrane and the posterior stroma, and a localized or a detached folded DM can be sometimes visible also. If you look at this video, you see that the surgeon was trying to get a small nucleus fragment, and as the tip is coming towards the wound, the hydration port, the fluid passing through the port causes the DM to detach. In this video, you can see how the surgeon is actually putting solutions at just at the wound, not inside the arterial chamber. So that is where, see here, the wound is not the place where you should put in the fluid. It should be inside the anterior chamber. Now you can see when he is removing the fluid, the DM is already detached. This is a video I have taken from cataractcoach.com, where you can very clearly see the wound. Exactly at the wound there is a irrigation port, and that is where the DM is detaching. Post-operatively, if the patient does not recover vision in about a week's time and the cornea remains hazy, especially the haziness is near the wound, then you must do a imaging to find out if the cornea is damaged due to endothelial damage, or is it because of a localized DM detachment. And if you find the DM to be detached, then you have to look for the free end to see whether it is rolled up or it is flat. If it is a rolled up, then it has to undergo a surgical intervention. If it is a flat detachment, then of course it can be conservatively managed. There are various classifications given by McCool, Samuel, health classification, which takes into account height, extent, length and position of the detached Descemet's membrane. But what is probably important is the classification by Sharma, which gives us how do we go about a superior detachment with a planar position of the Descemet's membrane. You can just do intracameral air and get away with it. But if it is a rolled edges, or if it is an inferior detachment, then in that case you have to go for a gas which is of which will stay in the antechamber for longer period. So management, it is mostly conservative because most of the detachments are small and limited to the wound area. So you can just absorb, or you can go give hypertonic saline rock inhibitors. That would help. If the detachment is bigger and it does not resolve over a period of a week or 2 weeks, then the wound must be closed. Air or a non-expansile SF6 gas, which is about 15 to 20%, should be injected, and avoid face down position. The patient must be told to remain supine, not prone. Give aqueous suppressants. Over a period of time, the DM attaches and the cornea clears. So to conclude, it is best to prevent if the detachment is small and is detected on the table. Suture the wound and give air. If it is large and detected on the table, give non-expansile SF6, which gets absorbed in 7 to 10 days. If it is not detected on the table and you suspect the cornea is not clearing up by 1 week of time, confirm by intersegment OCT, treat as per the stage. Indication of laminar keratoplasty is usually if it doesn't recover in 3 to 4 months, or if the corneal thickness is progressing in spite of medical management. Thank you for the patient hearing.
Thank you, Dr. Ashok Nanda, for wonderfully covering the topic. Most of the SICS surgeons or even cataract surgeons, they come to know that this particular complication has occurred or not. To identify this complication is the important step, rather than managing it further. But before that, you must be able to identify, and if at all it has happened, to manage it is very important, and that's what Dr. Nanda has covered. Thank you, Dr. Nanda. Thank you for a wonderful presentation. Now I invite my friend Dr. Jatinder Bali, who is a wonderful presenter, for his presentation on artificial intelligence. I think before he speaks, few things about artificial intelligence. Nowadays, people think that everything can be done by machine. Like when the surgeon is doing it, people feel that if it is done by machine, why the surgeon is needed? Maybe the criteria used by patients and relatives in future. So basically, it is not the machine which is doing, it is the surgeon. In case of artificial intelligence also, that risk may be there. That if something is done by artificial intelligence, why the man or the human being is needed? Why the surgeon is needed? But then there are some nuts and bolts which will be tightly done by Dr. Jatinder. And artificial intelligence is the important thing in cataract surgery. He will be delivering his talk. Over to you, Dr. Jatinder.
Sir, I think
Yeah.
वो नीचे से आया नहीं है अभी तक.
Please, ready,
So
get
please
ready.
bear with me. So very well, I think we can carry on with discussion with Dr. Nanda's this thing. A very fantastic presentation by him and very valid. So any patient who's not responding.
Anyhow, as Dr. Jatinder is getting ready for his talk, I think ISMSICS society is the international society for the small incision cataract surgery, and everybody knows it. It has got national and international chapters. We got a lot of foreign countries have adopted this technique of cataract surgery, and we have more than 3,000 members of the society. And our chairman, founder chairman, Dr. Amulya Sahu, and we invite the people, youngsters, to become member of the society. And the society, the registration, I mean, is about rupees 3,000 only. Please be a member and strengthen the society. It has got a lot of international reputation. I think it's ready now. Yeah.
Thank you so much, sir. Thank you. So at the outset, I want to thank ISMSICS for giving us this opportunity, and to AIOS, and I welcome all of you. So artificial intelligence, the goalpost has been changing. So today what we're going to talk about is the applications of artificial intelligence in cataract management. And I have no financial disclosures to make in this presentation. May Chalnira. So what we're going to discuss are only those which are either already commercialized or close to commercialization. We're not going into the deep analytics part of it. So what exactly has artificial intelligence been used for in cataract surgery? So it has been used for screening and diagnosis of cataracts, from taking the fundus pictures. It can screen there, from slit lamp photographs. It has also been used in IOL power calculations. That was the biggest use of it right up to very recent times. But now what it also does is it looks at different phases of the cataract surgery. It is able to identify which phase of cataract surgery it is. It looks at those instruments, and using those instruments it's able to identify which phase of cataract surgery it is. And if the phases are not following each other, it is able to pick up that there are complications which are arising. And timing each phase of the cataract surgery, it is able to calculate what is the average duration of a particular type of procedure for a surgeon, for an institution, and for a set of institutions. So going forwards, it is good for optimizing your theatre work, operation theatre workflows, and predicting your surgical timings. It is also able to identify PCO risk reduction strategies. So the first thing, of course, is classifying and detecting it. That is very simple. It's a walk in the park, something that it does routinely from fundus images and from photographs. And in fact, a couple of people in India are close to commercializing it. So those fundus images would be able to refer the patients to specific mapped out to locations. Surgery and how it identifies surgeries and surgical workflows. How it identifies the surgical workflows, we've already talked of. Then from the electronic health records, it is able to predict them, and from photographs and slit lamp images. Now, so far as IOL power calculations are concerned, The traditional teaching was that 22.5 to 24.5, almost all the formulas are going to work absolutely fine with some discrepancies. It's only when you have very short eyes or you have very long eyes that we need to be careful. And if you remember, we used to talk of Hoffer Q, and we used to talk of Barrett's, Huygens, and Holliday too. And do you remember this particular slide that we used to have back in those good old days? That some formulas are working better in some formulae work better for short eyes, others are working better for the longer eyes, and some for the entire duration. These were the third generation formulae that were there. So what has changed now? Basically, each of these formulas is just trying to work out the effective lens position where the IOL is going to go and sit after the surgery is over. Now, what has changed is that without actually calculating the ELP, it will be able to take into account the surgeon factors of thousands of surgeons and come up with an amalgamated result. So we have today the Kane formula, which is based on theoretical optics as well as regression in AI, and it is giving us good results, better than the third generation formulae. The next big one that we're looking at is Carmona. And mention must also be made of the Pearl DGS, which is using output linearization for extreme biometric values. And if you use geometric information, which the IOL manufacturer provides, then you can get better results than the third generation formulae. We all know LADA Super, which is using support vector regression and extreme gradient boosting for extremes. And Shramka is also using a neural network with ensemble model. So it improves the predictability linked to surgeons. So you're able to actually personalize your surgery to a particular type of patient in a predictive manner. The IOL Master 700 uses a swept source to give you total keratometry, which when you're using even with the traditional formulae is giving you more augmented and more predictable results. These are the studies which are already available for the diagnosis and screening of cataract, and look at the specificity there in the range of the 90s and area under the curve. For PCO risk reduction, we've already discussed it is for intraoperatively, it can measure it and actually slot the patients into those who will require more frequent versus those who will require less frequent follow-ups. Post-operatively, of course, the PCO can be graded, and it can actually place your patients from the EHR itself directly. So far as congenital cataracts are concerned, there was Lin et al. Gave us an AI screening tool based on the various risk factors that were there. It worked very well in China. And then we all remember Zhongshan's ophthalmics gave us the CC Cruiser, which was a cortical neural network for diagnosing and grading and initiating the therapeutic decisions in pediatric cataracts. And this became actually the CC Cruiser became CC Guardian when we adapted deep learning algorithms, and it was able to identify which patients will have a visual axis opacification and will require, that is in pediatric cataracts, which patients would require an intervention for visual axis opacification. So it is probably the way to go forwards, and so far as small incision cataract surgery is concerned, there is a lot of scope because we have a very large community. We probably are looking at creating collaborative research networks where all of us can put in our incision sizes, our patient data in an anonymous manner and get results out of that. So we're probably some distance away from it, but that's the vision of ISMSICS going forwards from here. Thank you so much.
Thank you so much, Dr. Jatinder Wali, for the wonderful presentation. Now I request Dr. Satyajit Sinha to come forward for his presentation. And Dr. Shiva Prasad Sahu is not there, right? So this is the last presentation of SICS session.
So a very good morning to the August gathering. I just wanted to share a small video of when it is so critical that you have to convert to small incision cataract surgery, even though you may presume that everything is running well.
Then you are going to wait for group photo, all speakers and chairpersons.
So this is the video I wanted to share with you. Once in a while we come around with a capsule which is so sticky, leathery, not sticky, so thick that you are just not able to even to begin with, even to puncture it, leave alone making a nick and then starting. So I'll show you in this video of how I'm going about it, and you will see that no matter how hard I try with the cystotome, I couldn't make it. Then I try with the Utrata forceps. It's so shiny that the visualization is also limited, and I think I have made a nick, but I have not. I use a Vanna scissors, but since there is no nick, I cannot extend the capsule. I'm trying multiple times. There is no nick, so I cannot even use my Utrata to go ahead. Now, once I catch the capsule over here, you will see I am putting so much stress on the zonules. You will see that the periphery, the zonules are getting pulled when I am trying to open this capsule. So this is not acceptable because we are putting so much stress on this already hypermature cataract. Now I try to go to the periphery to search if I can find another place to start the rhexis. And this is the time that I decide that since this is an edited video, I have already put a lot of stress on the zonules from around. So I convert to SICS, go and open the anterior capsule, and then I try to search, and still I am hopeful that I'll be able to make a rhexis. And since this is so leathery, and you can come across this in your day-to-day practice, so it's important that you handle the anterior capsule carefully. I try very hard, and even though I have made a nick, even though I have made myself safe by converting to SICS, but now I am able to get a grip, and you will see that right at the periphery I am able to get this rhexis margin. And even though I am trying to go around it, at one point again I get a thick capsule fiber, which from where I am not able to complete the rhexis. So again, because I have converted to SICS, because I am mentally at peace, there are a lot of maneuvers that I can do peacefully, which I could not have probably done if I was doing phacoemulsification. Thank you so much.
Thank you, Dr. Satyadev, for the wonderful presentation. I think we are coming to the end of the session. Dr. Shivaprasad Sahu is not there. And all the speakers and chairpersons are requested to come for the photograph.
And Dr. Satyajit, please accept thank you from all of us for the Bihar Ophthalmology Society. I mean, all of you have been very gracious hosts, and we have all loved coming to Patna. In general, LOC. Oh, wow. Namaste.